Siapa present?
Saya present.
Ha? Siapa present?
Saya present. Nur Fatihah.
Nur Fatihah. Oh, nak present kes apa?
Rapid breathing.
Macam ni introduce your patient ke?
No, doktor.
Introduce your patient properly. Introduce your patient properly.
Can you please repeat the question, doctor?
Introduce your patient properly.
Okay, alright. So my patient, 1 year, 11-month Malay boy, presented to emergency department with a complaint of rapid breathing 2 hours prior to admission.
Okay. Siapa lagi present? Kan 2 kes so prepare kan? Satu kes je?
Me, Natasha.
Kes siapa you punya?
Mine is 4 months old Malay infant with known history of eczema referred due to complaint of rapid breathing.
Ni lah kes. Present dulu Nur Fatihah. Mengaji dulu. Mengaji dulu ke?
Sorry. So this.
Aku makan meat tu kenapa mengaji juga?
Sorry doktor, saya terlupa mute.
Sorry
doktor, saya terlupa mute.
Terlupa mute. Mute. Okay.
So this history is taken from his mother. He was apparently well until he started to develop episodes.
Start semula nicely.
This my patient Muhammad Jebat, 1 year old, 1 year 11-month Malay boy, presented with the complaint of rapid breathing 2 hours prior to admission. So this history is taken from his mother. He was apparently well until he started to develop episodes of cough 3 days prior to admission. The cough was chesty in nature, did not have any specific pattern, gradually worsening. And the mother also said that it was associated with post-acid vomiting. The vomiting was non-projectile. The content was mainly milk and digested food particles. The amount was about 2 cups. There's no whooping or barking sound or hoarseness of voice noticed by the mother, no hemoptysis, no facial congestion, and no bluish discoloration noted. On the second day of admission, on the second day of illness, the mother noted that the patient was having rapid breathing at 5 p.m. in the evening as his chest was moving rapidly. It is associated with noisy breathing, and due to his worsening condition, he was rushed to emergency department and given nebulizer twice. And his breathing difficulties relief. During the routine assessment, fever was noted as his documented temperature was 37.5. And the mother noticed that the skin was warm to touch and it was generalized throughout the body. There's no chills and rigor. And the child was later discharged from home, at 11 p.m. on the same day with salbutamol cough syrup, mucolytics, and syrup paracetamol. The fever subsided for approximately 5 to 6 hours that day, after given syrup PCM, paracetamol, and tepid sponging at home. And at night, the child can sleep undisturbed. However, on the next day, which is the third day of illness, the fever and cough come again the following morning, and the child start to have another episodes of rapid breathing associated with noisy breathing, sudden in onset, occur at rest. So he was brought to emergency department, and on admission, the patient was able to talk only in phrases due to shortness of breath. However, he was still active and conscious, not drowsy and not confused. He used accessory muscle for respiration, but the mother denied any noticeable subcostal recession, no cyanotic changes, wheezing and stridor, no nasal flaring noted. Blood investigation was taken, and blood investigation and chest X-ray was taken. However, the mother was unsure about the result. Nebulized salbutamol was given, and oxygen was still low, so the patient was admitted for further management. Upon further questioning, he has underlying bronchial asthma diagnosed 2 weeks ago, because he was having the same symptoms: cough, wheezing, and shortness of breath. His asthma is classified as mildly persistent. In average, mildly persistent and partially controlled. In average, the child has 2 to 3 times daytime symptoms weekly, 3 nighttime symptoms monthly, and had history of recent hospital admission, which is in the same month, which is 2 weeks prior to admission. There's no exercise-induced symptoms, and the patient has not yet done lung function test. There's no daily activities limitation, no weekly requirement of reliever. Patient is currently on salbutamol 2-puff PRN and metered dose inhaler, budesonide 2-puff BD. And he was given further appointment on another 2 months in PIPS clinic. The mother also said that the patient had rhinorrhea and sneezing 3 days prior to admission. She denied any history of sick contact, no exposure to pet dander or carpet. Patient is allergic to seafood, but had no other known allergen, no history of exposure to noxious particle. For past medical and surgical history, this is his 5th hospitalization in hospital. His first admission was last year.
Why it passed? Tak apa, please continue. Continue, tak apa, continue. We discuss that later. Continue.
His first admission was last year, which is 12 months prior. Second admission was 3 months later, and his third admission was 6 months later, and his fourth admission is 2 weeks prior to this current admission. All are because of similar presentation: cough, wheezing, and shortness of breath. His range of days of hospitalization is about 3 to 4 days. He was discharged well and afebrile, and no history of intubation, no history of ICU admission. He was diagnosed with bronchial asthma on 4th admission. He was discharged with salbutamol and budesonide, and his guardian was counseled about the usage of aero chamber. However, the mother said that he had poor compliance to the medication, as he often refused to use the aero chamber. He had no eczema or allergy rhinitis. For drug history, there's no other medication or traditional medication or supplement taken other than the medication prescribed. There's no known allergy except for allergy to seafood just now. And immunization is up to his age according to vaccination schedule by Ministry of Health. No post-immunization complication. For birth history, antenatally, there is no complication. Intrapartum, he was born at 39 weeks of gestation at Hospital Pekan via spontaneous vertex delivery. And his birth weight was 3.3 kilo and postnatal was uneventful. For gross motor, he is able to run safely, avoiding obstacle. He can go up and down stairs. And for fine motor, he can build 6 to 7 cubes and enjoy picture books and can turn pages singly. For speech and language, he can name familiar object and pictures. He can use 2 to 3 words. For self-care, he is dry by day and can put on his own shoes. For nutritional history, he is exclusively breastfed up until 3 months, and he was introduced to formula milk at 4 months as his mother were having difficulties to breastfeed once she returned to work. He was given formula milk to grow during daytime and at night time. Okay, and at nighttime, he was given breast milk. At the age of 6 months, he started to introduce with soft diet, which is porridge and nestum. At the age of 1 year old, he was the formula milk was changed from Dugro to Fendif. And currently he is having adult diet with 3 regular meals per day. For family history, the mother and father are alive and healthy. His mother is 29 years old and his father is 32 years old. He is the only child. His mother has no known medical illness. However, the father, he had intermittent well-controlled asthma and currently on metered dose inhaler, fluticasone and salmeterol. He had no other history of atopy. For personal and social history, he lives in Felda Chini Timur with his parents. His house is equipped with clean water supplies and electricity. His father and both of his parents work as operator at motor vehicle company. Their household income is about 3,000 per month. Parents are non-smoker, deny taking alcohol and did not do deny any high-risk behavior.
Finish.
For
Finish
his
history only.
finish.
Okay. Azwa, any questions? Any question to the presenter?
Is there any history of exposure to smoking?
No.
Husna?
You have mentioned that the cough is worsening, but I would like to know if the cough worsen at night or in the morning.
No, and the cough does not have any specific pattern.
Ashraf?
Between the cough, is there any interval symptoms such as wheezing? Any interval symptom between the episodes, such as wheezing?
Meaning that, do you mean that the patient well in between accessibility?
Yes.
Yes.
No wheezing, no cough.
Yeah. Except for when during the hospital admission.
Norina.
Prior to the child cough symptom, does the child has any URTI symptom before that, such as sneezing?
Yes, the mother said that the patient has rhinorrhea and sneeze. He sneezed like about 3 days prior to start having rapid breathing.
Oisha.
Does the child need any reliever to relieve the symptom?
No.
Natasha.
Does the child compliant to the controller that was given?
The child had poor compliance to medication.
Amir.
Does the child have symptoms after vigorous physical activity?
No.
Lokman.
I would like to know why the patient has a poor compliance to the medication.
Pardon?
Why the patient has poor compliance to the medication, asthma medication.
The child refused to use the aero chamber. I think it is because of discomfort.
Any other questions?
Apart from the current symptoms, the previous admission due to what triggers? Is that due to URTI also, or no triggers for the previous attacks?
For previous hospitalization, the child had same episode. The trigger usually because of cough. However, there's no fever.
Any other questions?
Is there any activity limitation for the child, like exercise, running?
No activity limitation.
Any family history of asthma or any eczema or rhinitis?
The child has no eczema, no allergic rhinitis. However, the father has history of asthma, well controlled up until now, and his father is 32 years old.
You think all the previous admission related or not with the current problem?
Yes.
Then why we become past? Why you become past? Why become past medical history?
Oh. Yeah, I made a mistake, doctor. I should put it in the history of presenting illness.
Any other questions? Okay, Natasha, present. Natasha.
Yes, understand. Yeah, my patient Indah, 4 months old Malay infant. with a known history of eczema was referred from Klinik Kesihatan Kurnia to emergency department of HDA 2 days ago for rapid breathing of 1 day duration. The patient history began 3 days prior to admission when she developed fever, runny nose, and coughing. The patient had runny nose for the past 3 days, but her mother claims that it was not remarkable. There was clear fluid discharge from her nose after she finished bathing. Her mother does not sure about the amount of nasal discharge, but she said it was not a lot. According to her mother, the patient had an episode of fever before the runny nose started.
Let me start
it
with
was
fever
just
first. Which one come first? Fever come first?
The runny nose come
Come
first and
first.
then fever.
Okay.
Mm.
Continue.
But it was just low grade fever, so she stayed a cooling gel patch on Inda's forehead, and the fever resolved on the same day. The fever was not associated with chills, rigors, or fever. It was also not associated with
Amir,
rashes
mana
or
muka dia? Okay ha.
Okay. It was not also associated with rashes or mouth ulcer. Other than that, Indah also had episode of dry and chesty cough. Her mother claims that Indah's cough was not associated with noisy breathing at that time, and it was only low pitch. She denied any barking cough, hemoptysis, and vomiting after coughing. Furthermore, her mother explained that Indah refused to feed at night before the admission. She sometimes tolerate but with slow feeding rate. Her mother noticed that the patient hardly finished a 3-ounce meat, which never happened before she can finish it easily. But her mother did not notice about any loss of weight on her daughter. On the day of admission, Indah's symptoms appeared suddenly as she took a morning bath with her mother at around 9 a.m. Her mother claims that she was coughing continuously until she became difficult to breathe, and it was associated with nasal flaring. After the non-stoppable cough, the patient had episode of vomiting. As for the vomiters, it was projectile. And the mother claims that it was consists of white and clear mucoid and also contained the milk. After she vomited, the mother noticed Indah breathing rate was very rapid. However, the mother denies any breath discoloration of Indah's face and hand. The parent took action by bringing her to Klinik Kesihatan Kurnia. In the clinic, she was nebulized with salbutamol, which managed to give her relief. Her mother mentioned that the blood was taken from her daughter. And the result was normal. After a while, her mother noticed that Indah started to have a rapid and noisy breathing. Her mother told the staff and they nebulized Indah for the second time, but the rapid breathing did not resolve. The doctor in charge referred Indah to emergency department of the HTA immediately. Indah and her mother were brought to the by ambulance from Klinik Kesihatan Kurnia to HTA at around Maghrib. On the journey to the hospital, Indah was on nebulizer. Her mother remembered the medical personnel there said that Indah's oxygen level was low and they needed to monitor her condition, hence she was admitted. Upon further questioning, this is Indah's second hospitalization. The first admission was around 2 months ago at HTA when she was 30 days old. Her mother said it was due to upper respiratory tract infection. Indah encountered upper respiratory tract infection for her eldest sister who developed the symptom previously. In the hospital, she was suctioned for 6 days. She was also be given intravenous antibiotic by the doctor. Apart from that, her mother claims that the doctor diagnosed Indah with mild eczema of the abdomen and back part of the body. Furthermore, her mother mentioned that the doctor said Indah's heart was a bit leaking. Hence, she went for an echocardiogram check. Her mother said that according to the doctor, the leaking part was not dangerous for Indah. It had been healed by itself. But Indah need to be followed up for this problem. So the doctor said set a second echocardiogram visit During the second visit, her mother claimed everything went well for Indah and her heart was functioning normally. Her mother mentioned that the next echocardiogram visit will be on 17/9 next year.
This one is current admission ke admission yang lepas?
This one is current admission.
Current admission kenapa you present apa berlaku dalam ward? Current admission is only you tahu tak apa tu HOPI?
Yeah.
Huh?
History of presenting illness, current
Yeah.
admission.
Yalah, until bila? Until the child admitted to the ward. After that, you're not anymore HOPI. You dah year 5 tau, tak tahu lagi apa tu HOPI. I dah confused dah. Present semula.
Sorry.
Present semula. Ha.
Okay.
HOPI until admission. After that, it progress in the ward. It's not anymore HOPI.
Okay, so for the HOPI, the patient history began 3 days prior admission, which she developed fever, runny nose, and coughing. The patient had runny nose for the past 3 days, but her mother claimed that it was not remarkable. There was a clear fluid discharge from her nose after she finished bathing. Her mother does not sure about the amount of the nasal discharge, but she said it was not a lot. According to her mother, the patient had episode of fever before the runny nose started, but it was just a low-grade fever. So she stick a cooling gel patch on Indah's forehead, and the fever resolved on the same day. The fever was not associated with chills, rigor, or fits. It was also not associated with rashes or mouth ulcer. Other than that, Indah also had episode of dry and chesty cough. Her mother claims that the Indah cough was not associated with noisy breathing at that time and it was only low pitch. She denied any barking cough, hemoptysis, and vomiting after coughing. Furthermore, her mother explained that Indah refused to feed at night before admission. She sometimes tolerates, but with slow feeding rate. Her mother noticed that the patient hardly finished a 3-ounce meal, which never happened before, but her mother did not notice any loss of weight on her daughter. On the day of admission, the symptom appeared suddenly as she took a morning bath with her mother at around 9 a.m. Her mother claimed that she was coughing continuously until she became difficult to breathe, and it was associated with nasal flaring. After the non-stoppable cough, the patient had episode of vomiting. As for vomiters, it was projectile, and the mother claimed that it was consists of white and clear mucoid and also milk. After she vomited, the mother noticed Indah breathing rate was very rapid. However, the mother denies any discoloration of Indah's face and hand. Okay, for the past medical history, the first she was previously admitted on 5 June before around 2 months ago prior to the history of admission on HDA when she was 30 years old. Her mother said it was due to upper respiratory tract infection. Indah encountered upper respiratory tract infection for her elder sister who developed the symptom previously. In the hospital, she was suctioned for 6 days. She was also be given intravenous antibiotic by the doctor. Apart from that, her mother claims that the doctor diagnosed Indah with mild eczema of the abdomen and the back part of the body. Furthermore, her mother mentioned that the doctor said Indah's heart was a bit weakened. And she went for an echocardiogram check on the 11 June. Her mother said that according to the doctor, the leaking part was not dangerous for Indah since it has been healed by itself. But Indah need to be followed up for this problem. So the doctor set a second echocardiogram visit on.
Okay, yang cardio ni dia buat masa bila? Previous admission ke current admission?
Previous admission. This one is past medical history.
Kenapa past? Is continue ha? Okay, lepas tu?
She went for echocardiogram check on 11 June. Her mother said that according to the doctor, the leaking part was not dangerous for Indah. She can be healed by itself. But Indah needs to be followed up for this problem. So the doctor set a second echocardiogram visit on 18 November. During the second visit, her mother claimed everything went well for Indah and the heart was functioning normally. So
The
for
heart
the was functioning normally. Okay. And then for drug and allergy history, the patient currently take no prescribed over-the-counter or traditional medication. She had no allergies to food or medication, but
You baca you baca orang punya
yes.
Cara you baca orang punya macam you tak apa tu? You tak kaji kes ni. First time you baca ke?
No. I already read it last night.
Ya. You tak baca buku dan cara present. You tak nak cara baca buku, cara present.
Yes.
Tu different thing. Cara baca buku tau. Dia tak ada hati tu, tak ada tau. Macam baca buku je. It doesn't matter you nak present orang lain punya, tapi cara you present tu present, bukan baca buku.
Okay.
Cara you baca buku tu baca buku tak? Not sure how much you understand every word sentence what was given. You tell us. Menhayati. Continue. Lepas tu you baca laju-laju, unik, tak ada expression, monoton.
Okay. So for the growth history, her mother say according to the
You finish your HOPI dah?
Yes.
Alia, any questions?
Is there any reduced in activity during the rapid breathing?
Sorry, can you repeat your question?
Is there any reduced in activity during the symptom?
No, this only on the admission, the activity was reduced.
Nurul?
You mentioned that patient was given cooling gel, but does mother also give a syrup paracetamol, or also is there any recorded temperature?
No syrup paracetamol and no recorded temperature, only the tepid sponging.
Lagi? Ashraf?
You said that a patient has projectile vomiting. Is that the child has any convulsion or episode of fainting?
No convulsion and episode of fainting after
Not mentioned kan? It's no or not mentioned?
Not mentioned.
Not mentioned. So Fatihah?
What about the child food intake?
The child food intake was reduced because patient cannot finish 3 ounce meal. That before this, she can finish it.
Falisha?
Is there any cough associated with this?
Yes, there is a cough because patient have non-stoppable cough. Cough.
Norena?
Is there any history of sick contact prior to the child's runny nose, cough, and fever?
Yes, she had a sick contact with her sister.
Lokman?
just now you mentioned that the baby the patient had a non-stoppable cough. So I would like to know, is there any congestion of the face?
Sorry?
Is there any redness or congestion of the face due to unstoppable cough?
Oh, it doesn't mention here. So sorry, I could not know.
Amir,
Does the patient also have symptoms of meningism?
Oh, so not mentioned here about the symptom of meningism.
any other questions?
Regarding the unstoppable cough, is there any like cessation of breathing?
There is no cessation of breathing.
Natasha, I just want some clarification. The patient presented with fever first, then runny nose at the same day, right?
No, before she had runny nose for 3 days, and then uh, on the admission she had a low grade fever. So the runny nose come first and then fever.
Any other questions?
Any symptom of heart failure symptoms such as sweating during feeding or any FTT?
It was not mentioned here.
Natasha,
Yeah.
just now you mentioned that this patient has noisy breathing. Is it the noisy breathing at the very beginning of the symptom around the fever and coughing?
No, the noisy breathing are only developed, which is on the day of admission, during the patient having vomiting after continuous coughing.
Any other questions?
Is this the first time that this child has experienced this symptom?
Yeah, this is the first time, but this is the second hospitalization. It is not the first hospitalization.
Does the patient have any food allergy and other history of atopy?
There is no food allergy, but the patient has eczema at the back of the at the abdomen and the back of the body.
Does the family have a history of atopy too?
Family no family history of atopy, but her father have also diagnosed. No. No history is atopy in her family.
Noalia, you listen the history, both presenter just now. In your opinion, during admission, which one more severe? The first one or second one?
I think the second one.
Why second one?
Because I mean the current admission, because she developed rapid breathing.
This first one also got rapid breathing.
Might be because of non-stoppable cough, and also there is a reduce in feeding.
Second case, so first case got reduce of feeding.
Dato, may I answer?
Dilo, your time will come. Nurul,
Yes.
what do you think?
I think the second case as well,
What?
because mother mentioned that the medical personnel said that her daughter oxygen level is low.
So the first case.
But the first case patient can still talk in phrases even though
Yeah,
has
we expected for month-old talk on faces.
no. Maybe we can look at the alertness of patient. Because the second case, the child has an unstoppable cough and
Has what? Pardon?
unstoppable cough. Unstoppable cough.
Unstoppable cough. So you mean that the child's not alert?
No, patient. We cannot say that. I think
Second case got recession. The first case got recession.
yes. So maybe the first case is more severe.
Tukar pula. Ashraf?
I think the first case, because the first case has more multiple exacerbation, multiple admission to the hospital.
We don't talking about the multiple as version. No, because that one is different. This one different issue. The issue is that when the child came to you, when you are alone, let's say you are a doctor alone, this 4-month-old baby who come, and then there is this first kid how old?
1 year, 11 months.
2 years old. This boy coming. Which one you choose to treat first in your assessment? Which one more severe?
The younger patient, because it's more severe.
Why you think that one more severe? Second case.
Because
what is your clinical evidence from the history? You think that the child, the second one, is more severe?
Sorry. Because I think it's the first case. Because the first case, the diagnosis is more likely to be asthma, but for the second case, based on the age, is 4 months. It's more on acute bronchiolitis, which is the
You mean acute bronchiolitis is less severe than asthma?
Yeah.
There are many asthma dalam klinik, dalam ward, dalam dekat goes to the GP, nebulize balik rumah, tak ada apa, tak ada masalah. You mean that you diagnose severity in terms of clinical diagnosis? That's how you diagnose severity. There are many children who asthma who just when even ada tak masuk ward lalu yang kena exacerbation kat rumah, mak kasih MDI, then they need to go to hospital pun.
Because on the first case, on the day 2 of the illness, even a patient was given salbutamol syrup, the patient still developed.
Poor compliant.
No, the syrup, the compliant is MDI. The non-compliant is for the MDI for the.
How you know that the dose is adequate?
We have to investigate that.
I don't know. Probably the dose syrup is not adequate. Nobody. He didn't tell me the dose.
Okay.
Fatihah?
Yes, doctor.
Which one more severe?
I think the second case,
Why?
the woman old, because the first case, the case that I presented, we already have a diagnosis. However, the second case, the patient has no diagnosis yet, so it is unpredictable compared to the first case.
You mean that no patient died because of asthma?
The 4 months baby have underlying heart problem.
Cardiac problem. But doctor done echo and doesn't mean that he didn't worry about at all about the cardiac. Teruknya assessment severity. Fawisha, tak sabar jawab tu. Okay
Actually, my reason, I would choose the second case to be more severe, just because the patient is much more younger, and
clear
this is the
lagi?
first presentation, and like we don't really know, like we don't have the diagnosis yet. Just like
You mean that no patient died because of asthma?
no, because
Once
in the
you
first,
diagnosis, I mean that it's not severe. Have few cases who die because of asthma, ICU ventilated.
I think based on my judgment, the first case is basically the patient isn't compliant with the medication, and
So
we've
it's more
already
severe lah,
done that.
no compliant medication at all. Usually those
Yeah,
who do
but we
compliant
can manage
medication yang teruk masuk ward.
Okay.
Can I try, Doctor?
Hello. Norina?
I think the most severe case is case 1. Due to the presentation, the mother suggests that the mother noticed that the child had rapid breathing with usage of accessory muscle.
The second case don't have usage of accessory muscle, or not mentioned.
It was not mentioned.
No, not mentioned. That doesn't mean doesn't have. Anything else? Okay, you have the facts. One is accessory muscle usage. Anything else? I mean, your line, the thinking is correct lah. You got some kind of thinking process. So that's all you boleh ni. You punya tu. Lokman?
I think between the first and second case, I will choose a second case as a severe one.
Why?
Because first, I would like to consider the age of the patient, and the second one is because the patient had a difficulty in, the reduced oral tolerance.
The first case does have reduced in oral intake.
I think no reduce in oral intake.
You all mix up between not tolerate orally, reduce oral intake. Itu tak difference between that. Not tolerate oral intake and reduce oral intake. Do you know the difference between that? Tak tahu.
Can I try?
Nah.
Cannot tolerate orally, the child cannot eat. Reduce oral intake, the child eat but in small amount.
So apa susah sangat? English je. It's English. Amir.
In my opinion, the more severe case is the second case, because first patient already have noisy breathing. Noisy breathing means the airflow obstruction is
What kind
severe.
of noisy breathing the patient is having?
What, Doctor? Pardon?
What kind of noisy breathing the child is having? Did they mention or not?
No.
Anything else?
The patient also have nasal flaring, which indicates the effort to breathe.
Anything else?
And also patient complain of reduced feeding.
Reduce feeding ke not tolerate feeding? Which one?
I think reduce. Natasha, is it reduce or?
What you want to ask now? Why you say reduce? How much reduce is that? When the child vomit? After feeding, during feeding, before feeding?
After cough. After patient coughing.
After?
Patient coughing.
Coughing, lepas tu?
And then she vomit.
Okay, then the feeding was what you mentioned.
For the feeding, patient hardly finish 3 ounce milk.
Hardly?
But before finish 3 ounce milk. But before before the night of admission, patient refused to feed.
Itu apa benda tu? Reduce feeding or not tolerate feeding?
Before it doesn't.
When patient refuse to feed, is not tolerate feeding ke reduce feeding?
Not tolerate feeding.
Aduh, letihnya lah. Apa benda you pick up history ni? You tengok, you see, you are the one who history, you tak analyze history, you tahu tak? In front of you. You tahu tak, I tengah correct paper tau. Sekarang ni. I dengar history at same time I correct paper. I baru dengar you punya history buat tadi, baru dengar. Bukan 2-3 minggu lepas baca. I can only decide the child is can tolerate feeding or not. What is the other thing important about this case?
In the first case, the patient had rapid breathing at rest. In the first case, the patient had rapid breathing at rest.
The second case don't have rapid breathing at rest. Macam mana doktor, you cannot decide, you know? Which child was given oxygen, still saturation not good?
The second case.
Tak boleh decide. Natasha, tak boleh decide.
Second case.
The child was given continuous nebulizer. You think continuous nebulizer kita pakai apa? Oxygen tau. And then what the nurse said? Saturation is not?
Still low.
Still low. Even the history is not complete. We don't know the full recession or those things, but from the history you already know which one is more severe. The first case need oxygen, but it seems to be stable with that. Adwa, what the essence of the first case?
The essence is 1 year 11-month Malay boy presented with rapid breathing 2 hours before
Nurul?
admission.
Patient 1-year-old 11 months boy presented with rapid breathing and
Ashraf?
Patient has non-compliance to medication.
Nur Fatihah?
1 year, 11-month-year-old with underlying persistent mild and partially controlled.
Alisha?
The essence for the first case is rapid breathing for 2 hours, and the second
Norina?
Oh, 1 year, 11 months boy presented with cough and fever.
Lokman?
Rapid breathing due to unconscious.
Amir?
2-year-old boy
You all need to talk letak year lagi lah.
presented with acute exacerbation of bronchial asthma.
Nur Asha?
Apa URTI breathing that exacerbate the asthma?
Okay, first of all, I don't agree that nurse of asthma in this case yet. Looking at the history, I think there is more than that. I don't know who diagnosed asthma. If the child is diagnosed through asthma, the child is a 2-year-old asthmatic child who having acute exacerbation. It's asthma, but I disagree with that because looking for the history, I think it's not yet asthma. I thinking this is a child 2-year-old child with recurrent. Recurrent apa?
Pneumonia. Pneumonia.
Speak lah. Recurrent?
Wheezing.
Wheezing.
It can be recurrent wheezing or recurrent shortness of breath. It can be either that one. I more think of recurrent wheezer, but this child with recurrent shortness of breath. But if the child is asthmatic, this is asthmatic 2-year-old asthmatic child who are having acute exacerbation. Second case, Alia, where there is second case?
4 months old presented with viral bronchiolitis.
Nurul,
4 months old with recurrent wheezing due to acute
With what?
bronchiolitis. Recurrent wheezing.
Ashraf,
Second case is more severe.
pada accent, dia tahu tak question I apa benda. You listen tak my question ni. My question to you, what is the second case make sense? I don't ask about the, ni kita dah go past that one already. You kat mana? Somewhere else ke?
The second case has 4 months with acute bronchiolitis.
No Fatihah?
4-month-old legal presented with rapid breathing and symptoms of upper
Dia
respiratory.
dah okey dah. Waktu sampai you tak boleh ke fikir pendek je? Farisha? Mesti nak tambah lebih-lebih lagi otak you. Otak perempuan macam tu. Mesti nak tambah benda extra. Tak boleh fikir short, concise. Norina?
4 months.
4 months infant with URTI symptom.
This you tahu lagi teruk pemikiran you, tahu tak? You tell me kan you tak faham case at all. Dia tahu what kaitan with URTI with shortness of breath. You are a dangerous doctor tau. URTI is not an issue at all. Lokman?
4 months old girl presented with respiratory distress. Due to bronchiolitis.
Amir?
4 months with severe respiratory distress secondary to infection.
Natasha?
4 months old girl presented with viral bronchiolitis.
That's what a problem with you. You become biased of the diagnosis. We have not yet go through the physical examination and diagnosis. We're still discussing about the history. Because you all tak lepas lagi nak go physical examination and diagnosis. You're still on the history. That's why you are biased. Many kind of thinking process you tak tahu kat mana, kat which level the thinking process should be. We're still in the history. The street told us this is a 4-month-old child with shortness of breath for how many days?
1 day duration.
For 1 day. Acute shortness of breath. The first case is a 2-year-old child with recurrent shortness of breath. For this case is a 4-month-old child with acute shortness of breath. I ask you, if you're talking about foreign body, which one is likely to get it? The first one or second one?
First one.
Huh?
The second one.
First one.
This is 4-year-old child with recurrent shortness of breath. Your presentation history, you see, always is similar with other previous admission. The presenter already told you that the presentation is similar from the other, with the other. So which one is likely to be foreign body, the first one or second one?
Second one.
The second one, because it's acute.
When we're talking about likely, that doesn't mean is 100%. In medical terms, we look at them likely, possibly, high chances. So in this case, 4 years, 1 year to 4-month-old child with acute shortness of breath one day. What the next thing come to your mind?
Pneumonia.
What we call that? What the next thing come to your mind?
The causes for the shortness of breath.
Amir, bagus. Adalah seorang yang boleh berfikir cara apa tu? Conceptualize. Yes, we want to know the causes of the shortness of breath. Acute shortness of breath in this baby. Before that, what you need to know first, you must have something in your mind, in your brain first, before you can answer the question, what is the causes of shortness of breath in this baby?
The risk factor for.
Not the risk factor. Apa benda? You baca setiap hari, you baca benda tu.
Is it a term baby or preterm?
What you need to know? All the causes of shortness of breath. What the possible causes of shortness of breath?
Infection.
Ni doktor
Body.
lah. You know doktor kan? Kalau tanya infection kan, the first question I ask you, cellulitis. Tak boleh you fikir. Upper respiratory infection. Upper respiratory infection cause shortness of breath.
Pneumonia.
Ada. Tahu tak? Cara you fikir, tell me your level, tahu tak? Benda tu, ting. Pneumonia lagi.
Respiratory distress syndrome.
Astaghfirullahaladzim. 4-month-old.
Bronchiolitis.
Lagi.
Orange body aspiration.
Lagi.
Viral cook.
Lagi. Where you get all the knowledge?
Book.
Yeah, for the book. That's the reason you read your book. To sort out the patient problem. Apa lagi? Okay, is this patient possible croup or not? Natasha. You see, the causes you can hafal. You have no choice. You have no choice. You can hafal. But the problem is you baca, can you catalog inside your brain? You have to come out when the case like this. But can you do that? I found out you cannot do that. Because the reason is that you baca nak exam. Bukan about the patient. Suatu tak berkat, tak keluar. Itu susah nak keluar. Because you don't think about your patient. Natasha, do you think it will croup or not this case? So you have to know the future of the croup. And you look for the history you present. You look at the history. Can your croup fits or not with the future clinical history of this case? Amir. Orang yang ada berfikir logik sikit pada the rest ni. Nak test you tengok. Do you think this patient got heart failure or not?
No.
Why you don't think patient not heart failure?
because the symptoms patient presented is more towards the respiratory symptom and no feature of heart failure such as
Apa such as?
Bluish discoloration of the face,
You mean that heart failure cause cyanosis?
edema, fluid
At this
overload.
age, edema is mean future. Tak boleh answer. As this age, what you expected, your patient got heart failure, what your future going to be? Tak ada knowledge. Yeah. Of course, they have tachypnea. They have rapid breathing. They also have a feeding problem, sucking slow, failure to thrive. When sucking, they are sweaty. You won't expect edema in this case. Husna, you think it's foreign body or not?
Can happen because it is acute onset.
That's all.
And
Everybody knows that. Year 3 pun tahu. But for you, what is the criteria history, with history that tally with the foreign body in this case?
is there any choking or
Oh, tanya I tanya you. You dah listen to the history. I'm asking you now.
history does not mention any choking or
When you listen to history just now, did this thing run through your mind or not? Tak run through your mind. You dengar je. This second case, this child is current wheezer, or this child is a asthmatic attack with acute sedation. What do you think come to your mind?
maybe acute bronchiolitis because
Feeble-nya lah.
The severity of attack.
The
severity of the attack.
Kita dah discuss, dah habis dah benda tu. Apa lagi kita nak pergi? We discuss already. Severity ni. You dekat mana, Ashraf? You follow the discussion ke tak? What the next thing come to your mind? Hello? Salam, ha? Ya. Maksudnya? Temperature? Oh, tinggi ya. Kita rasa tak Kawasaki ke? Tapi kenapa? Apa benda dia tu? Ada apa lagi? Dia tengok itu. Kaki dia tu lagi. Tapi you tengok history elang dia tu ada tu sikit. Changes dekat ada tu the right side dia punya cardiac margin dia tak smooth. The right surfing cover lah. Ada respon tak closer? You tengoklah, kalau tak respon closer besok you start limit penuh. Tengok kalau closer tak jalan start limit penuh besok. Dia punya margin cardiac dia semua tu, dia punya physiology margin dia tu, you repeat today kan? Tak, so dia punya tu balik ESR, DSRP semua repeat hari ni. For better sikit ya. Dia punya HB tu sembilan. Tapi keadaan dia sama lah, dia masih di full macam tu. LP je lah. Tapi LP je lah nanti. Off lah. Ya. Tapi PCN dia buffen ada juga. Tapi PCM ni kalau you follow the dose not to go up even you pakai banyak lama pun. Ya. Ya. Sama dia lah apa ni dia punya tu title dah. Tapi dog ya. Ya. Tapi yang for Scott typhus will be ini kan tu will fill test. Yeah, reverse now. Apalah you wait for a while for the ni. Tengok apa tu kalau tak jalan itu independent lah besok. Tapi dia punya mentu semua mantu stay kan. Negatif lah. Lebih negatif. Dengan mentu je lah. Tapi dia punya yang tu tapi X-ray tu is ni ada something ada apa tu? Right hela tu. Apa tu ada shape dia tu is funny. I'm thinking kan semua tak jalan fever OCT je. Tapi tak apa tengok dulu. Ya. Ya. Bajikan and then the things that kalau kita dah ni semua tengok macam mana bincang dengan kos kalau kos dia sanggup pergi ke tu tak pergi ke HTA. COVID. Apalah. Tapi dia memang you notice temperature dia macam tu ya. Ya. Malam ya. Malaria aktif kan. Berapa hari ya? 10 hari ya. 11 hari ya. Fikir ya. Tapi rasa cover semua everything. Budak tu aku plasma kita hantar. Ya. Cuti. Betul. Ya. Lepas review besok lah semua. Everything. Sama ada kita need to upgrade dia ni. Budak tu toxic tak toxic kan? Ni. Tapi kalau dia tak keluar ya. Kalau FP, what do we want to find? Sama lah, apa doktor jumpa apa. Usually kalau pelik-pelik macam ni, infectious disease yang lama ni, dia akan start either betrin atau tetracycline. Betrin. Apalah, you start with closa, tengok gossiping closa barat dah boleh cover dah. Kalau ada so it can be betul sinusitis can cause fever like that or not? Temperature niggling macam tu. Ya, self-limiting, tapi self-limiting you mean that how high the LFP dia tu? Tapi LFT high ni kadang kita off ya, atau opinion. Gossiping berapa hari dah? Cuba check gossiping dengan liver function test. How did they advise? Memang ada, tapi more in less 1 year old. Do we check do we reduce the dose or do we off the check dalam? Because I'm thinking of kadang-kadang rasa nak off semua. Off semua dan tengok. Thinking to off everything dulu. Go 24 hour. Lepas tu think of what the next antibiotic want to use. Thinking of that. Or ada viral infection yang, so the next stage viral or bacteria. If bacteria, where it will focus? Kalau dah toksik belum cari globulin. Tak apalah. Tak toksik pun. Tak apalah, we tu dulu, tak apa. We tu dulu and then we inilah probably if you think memang sopin dia advance to off tu, you off dululah. Perhaps we off everything for 24 hour and then we do balik, we sit down ni petang besok after going round besok kita discuss apa benda nak go through all over again. Tahan lah budak tu, rasa dia seperti shock tak kalau kita off sekejap semua everything. Kita tengok dulu kalau dah 2 hari 3 hari habisnya I give 48 hours ya. After 48 hours I terus respond lah. I really tempted to start meropenem, tapi dulu lah tengok. So alang-alang meropenem ni di bahan semua CNS pun cover je. If tak jalan dengan meropenem, probably we have something very odd go battery atau apa, and the second thing baru goes to the apa tu ni. Tapi kalau cost factor nanti bincang lah kalau ada. Kita refer dulu pada tu, patient tak ramai. Tapi yang bagus ni dia seorang kat tu kan, dekat di Acute, tak ada orang lain. Okey lah. Okey. Apa tadi? So what the next thing come to your mind? This is a child with recurrent wheezer or asthmatic attack with you want to know what the
Trigger.
What trigger the attack, the acute exacerbation? Why the child got recurrent the next So in this case you have to know what is the basis, what is the recurrent wheezer all about? Is it asthmatic or just a multi-trigger, or is that a recurrent wheezer? Child recurrent wheezer, or if the child asthma, what trigger the asthmatic attack? So this one. So what trigger the asthmatic attack? It can be what? Triggers URTI, smoke, or
exercise.
It can be poor compliance, medication inadequate, wrong technique. So the history answer if the history answer all that thing. They see the answer all those things. Okay, any questions? Ada letih dah. Kedua kan ada ni. Satu lagi teaching. Rasa tak letih ke mengajar you all?
Letih.
Letih dengan you all ke letih dengan case?
Dua-dua.
Dua-dua. Pandai. Tak diplomatik. Course. Okay, ada apa? So, you beritahu orang yang seminar tu nanti dia besok atau lusa tengok. Ada seminar satu dengan you all kan?
Ada.
Tak besok atau lusa. Okay, we go through besok atau lusa. Oh, you all kat mana sekarang? Rumah?
Saya dekat Mahala.
Dekat Mahla sekarang?
Saya seorang je yang dekat kampus.
Ya, siannya. Tak sunyi ke?
Ada posting lain juga.
Posting lain? Adik-adik?
Tapi dalam grup ni saya seorang je lah yang dekat kampus.
Ya. Okey lah. Tak tahu kenapa you all tak boleh balik. Ya. Tak boleh balik lagi?
Belum.
Asyik lah tu. Okey. Sebenarnya jadual pun tak sure dah macam mana. You ask me. Nanti pun tak go through jadual. Semua orang confused. 2 minggu lagi tak tahu apa jadi. Okey lah. Nanti we go through. Tapi we go settle. Ada seminar je kan? Tak ada dah kan? Mengajar face to face. Sini susah sikit nak mengajar. Okey, tak pas lagi, tak boleh pergi pada physical examination lagi. Okey, apa you rasa dah best lah presentation tadi? Mungkin lah kalau phone jadi houseman, okey lah. Tapi if you to think become a doctor, it should be better than that. Kerana nak pass, kalau you fikir nak pass exam saja, hidup you all decide nak pass exam saja, that the most important thing, okey lah tu. If you decide, pass exam the most important thing, dan tak ada apa-apa lah. Kan? Pass exam the most important thing. Ya. Tak tahu. Tak sure.
Bukan.
Okey. Okey,
Bye.
Thank you semua.
Thank you.
Thank you.
Thank you, presenter.
Presenter.
Thank you, presenter.
Thank you.
Thank you.
Thank you.